All right, so this represents just a lecture for the shelf review. Hopefully you can use this as sort of prep for your upcoming family medicine shelf exam. So we can get started. This is a series of questions related to diabetes medications as well as screening and other things that we would do for diabetics, such as like urine microalbumin screening, statins, questions about whether aspirin's indicated, et cetera. So question one. Sally is a 55-year-old female with a past medical history of type 2 diabetes, as well as hypertension and chronic kidney disease stage 3, who presents to the ER for a chest pain rule out. The ER physician wants to perform a CT angiography to rule out a pulmonary embolism. Her A1C is 7.5%. She is currently on metformin 1,000 milligrams twice a day, Levemir 35 units at night, atorvastatin 40 milligrams, and amlodipine 5 milligrams a day. Which medication should be stopped? Is it A, amlodipine, B, atorvastatin, C, Levemir, or D, metformin? So the best answer is metformin, although there's some controversy about whether or not this needs to happen. So metformin is a biguanide. It is the most common and currently only medication in this class in the United States. And just remember the mechanism of action is it decreases hepatic glucose production, aka gluconeogenesis. And it also increases insulin sensitivity peripherally. So your fat tissues, your muscles are more likely to respond to insulin, so to store it as so glucose can be stored as either fat or into glycogen in the muscles. And it also leads to decreased intestinal absorption of carbohydrates. So because of that decreased absorption of carbohydrates, one of the biggest side effects of metformin is going to be GI side effects, typically diarrhea, flatulence, etc. But the medication is great. It reduces microvascular complications. There's pretty decent weight loss benefit for the medications. It reduces the risk of cardiovascular events and increases or improves mortality in patients with type 2 diabetes. And there's pretty good bang for your buck in terms of lowering A1C. Generally, patients can see anywhere from a 1 to 1.3% drop in their A1C. And we mentioned the side effects. However, if they end up having this, you can actually switch them to an extended release formulation of the medication that tends to be better tolerated. Now, going back to the previous question, metformin is somewhat dangerous in people with chronic kidney disease. When I was a med student, the rule of thumb was if a male had a creatinine of greater than 1.5 or a female had a creatinine greater than 1.4, you would have to stop metformin. However, in 2012, KDIGO, which is essentially the foundation for nephrologists and doctors that deal with dialysis, they actually said that, it's fairly safe to use metformin in patients with chronic kidney disease. You don't have to completely discontinue it. However, you should reduce the dose based on someone's renal function. And sometimes you should completely discontinue it in patients with a GFR of 30 or less. And the reason being is that it doesn't really damage the kidneys, but with reduced renal function, there is a slight risk of lactic acidosis in patients with reduced renal function. And because of this, everyone's scared about keeping metformin with someone who is getting a contrasted study. The evidence doesn't really support it, but we still do it because of that risk. I know that when I order a contrasted study for my patients, I have to include whether or not they're on metformin. And sometimes I'll be asked to hold it for about 48 hours prior to the study. But, in emergent situations, you can still provide that contrasted study because the net benefit is greater than the risk. It's usually for patients that need elective type imaging. So question 2, Mr. Anderson is a 78-year-old male with a past medical history of type 2 diabetes with an A1C of 6.5%. He's having episodes of sweating, fatigue, dizziness, typically after taking one of his diabetes medications. Which of the following is most likely to cause Mr. Anderson's symptoms? Is it pioglitazone, sitagliptin, glipizide, or metformin? All right, glipizide. So glipizide is a sulfonylurea. Mechanism of action is it binds to potassium channels in beta cells, and then that stimulates the release of insulin from the pancreas. The biggest side effect is weight gain and hypoglycemia. So if you remember Mr. Anderson, he's older and he's having sweating, which typically can be a symptom of hypoglycemia. The medications, sulfonylureas, are fairly cheap and very affordable compared to the other non-insulin therapies for diabetes. They can lower A1C by about 0.4% to 1.2%. There's no benefit in terms of mortality or cardiovascular outcomes. In fact, in some of the earlier trials for diabetes, particularly a core trial, there was actually an association of glipizide and other sulfonylureas with mortality, which is why they've kind of fallen out of favor. But they are a very affordable option, especially for patients that don't have any insurance. And that risk of hypoglycemia increases as patients get older or as their kidney function declines. So if you have someone that has a history of chronic kidney disease, or if they're older, I would highly caution you in trying to use this medication. And sulfonylureas are on the Beers list of medications. So you'll learn this in geriatrics your fourth year. Hopefully you'll get a little exposure, but there's a list of medications that tend to be not ideal and not as safe for patients over the age of 65. And sulfonylureas typically be the ones that fall up in that list. So question 3, which of the following medications is the most associated with weight loss? Is it A, glipizide, B, pioglitazone, C, liraglutide, or D, levemir? And the answer is liraglutide. So liraglutide also goes by the trade name Victoza. It's a glucagon-like peptide receptor agonist. And the way it works is it increases insulin secretion from beta cells, decreases glucagon secretion from alpha cells in the pancreas, suppresses hepatic glucose production, and delays gastric emptying. Typically, patients will expect around 1 to 4 kilograms of weight loss when they start at GLP-1. Excuse me. Side effects include nausea, vomiting, and a sense of fullness. Pancreatitis can be a rare complication. It can lower the A1C by about 0.8 to 2%. And there is a box warning for anyone with a history in their family of medullary thyroid carcinoma or MEN type 2 syndromes. So that's a black box warning for the medication itself. GLP-1s have really good weight loss benefit to the point of where they're now being prescribed specifically for weight loss in patients without a history of diabetes. So just keep that in mind. Question 4. Mr. K is a 35-year-old female with a recent diagnosis of diabetes mellitus who presents to the ER with tachycardia, tachypnea, and somnolence. Vital signs show an elevated heart rate of 110, a blood pressure of 105/55, a respiratory rate of 34, and a pulse ox of 98% on room air. Labs show a creatinine of 1.78, a bicarb of 18, a sodium of 126, a glucose of 756, a chloride of 104. Her physician recently started her on a new oral diabetes medication. Which is the most likely to cause her symptoms? Is it metformin, liraglutide, pioglitazone, or dapagliflozin? So it's dapagliflozin in this case. And going back to the original question, I'm just going to go back to a couple slides back. The most likely presentation for this patient is that they likely have diabetic ketoacidosis. One, their bicarb is low. They're hyperglycemic, and that sort of tips you off that maybe there's some DKA happening. The most common non-insulin therapy that leads to ketoacidosis typically is your SGLT2 inhibitors. And so we're going to talk about those in the next slide. So there is a black box warning associated with SGLT2 inhibitors, and that they can cause DKA, but they typically cause a euglycemic diabetic ketoacidosis. So you may get a presentation of a patient that comes in with ketoacidosis, but their blood sugar is stable, but they do have an elevated NI and GABA. So that should tip you off to a possible SGLT2 inhibitor. The way they work is they block sodium glucose transport in the kidneys, and then patients will essentially urinate. When they urinate, they'll have an increased blood sugar concentration in urine. And because of that, they can have side effects such as urinary tract infections, fungal infections, and possibly an increased LDL. These medications are typically associated with weight loss of around 0.7 to 3.5 kilograms per person. However, there is cardiovascular benefit. There's actually renal protection with these medications. You can use them for patients that have nephrotic syndrome. Anyone that has diabetic microalbuminuria, if they're already on an ACE or an ARB, and their GFR is I think greater than 30, you can actually use these medications to prevent further degradation of their kidneys. And they also have a really good benefit for congestive heart failure with reduced ejection fraction. So they're included. You can actually use it to treat heart failure patients without diabetes as long as their ejection fraction is reduced. There used to be some concern that this class of medications was associated with peripheral artery disease limb amputation risk. However, subsequent studies haven't really confirmed that. So it's not as big of a concern as it used to be. Question 5. Mr. Smith is a 65-year-old male with a past medical history of type 2 diabetes, hypertension, who is having progressive shortness of breath. He sees his primary care physician who performs a physical. Findings show 2+ pedal edema, increased JVD and crackles. He's also gained approximately 5 pounds since his last visit. Mr. Smith states that he can only walk approximately 5 yards before feeling short of breath. So Mr. Smith is having symptoms that might typify heart failure. And so the next question is, which medication would lead to someone having heart failure or having a heart failure exacerbation? Is it insulin detamir, also known as Levemir? Is it exenatide, also known as Bydureon, if it's once a week, or Byetta, if it's twice a day? Glipizide, which we talked about, or pioglitazone? And the answer is pioglitazone. So we're good? It appears that he's having signs of heart failure. So, the shop exam is not going to tell you what's happening. They're going to give you telltale signs of a diagnosis, and you're going to have to sort of think backwards as what could have caused it. So based on staging, he likely has stage 3 to 4 heart failure, just based on his symptoms, his inability to walk very far. And if this guy's presenting your clinic, you obviously don't want to wait around. He obviously needs to probably get evaluated urgently, but for the purposes of this lecture, just remember that TZDs can increase the risk of congestive heart failure and are contraindicated in anyone that has class 3 or 4 heart failure. So the way TZDs work is they increase hepatic glucose uptake, they decrease hepatic glucose production, they increase insulin sensitivity in muscle and adipose tissue. And if you're thinking about the mechanism of action, just remember PPAR gamma, and you can look it up and see the cool little flow diagrams. But the side effects include weight gain and swelling. And again, they're contraindicated in people that have heart failure. And so typically, if patients are on this, if you're starting insulin, it can cause hypoglycemia, so you want to use insulin with these patients consciously. So question 6. Ms. Jones is a very pleasant 55-year-old female who presents for an acute care visit. She was started on a new medication, although she cannot recall the name. She has upper abdominal pain that extends to her back, but she's also vomiting, she's nauseous, just not feeling very good. Vital signs show an elevated heart rate of 105. Her blood pressure is lowish, 110/75. She has some tenderness and palpation in the epigastrium. Labs reveal a white blood cell count of 10.5, a hemoglobin of 13, platelet count of 205. She has a comprehensive metabolic panel, which shows an AST of 25, an ALT of 35 with normal electrolytes and creatinine. Lipase is 205, which is elevated. Which of the following medications is the most likely cause of Ms. Jones's presentation? Is it amlodipine, linagliptin, metformin, or glipizide? All right, linagliptin. So linagliptin is a DPP-4. And the way it works is it increases GLP-1 and thereby increases insulin secretion from beta cells and decreases glucagon secretion from alpha cells in the pancreas. These medications are typically weight neutral and very well tolerated. And the most common application is these medications will oftentimes be combined with metformin. Patients will typically have an A1C reduction of 0.5 to 0.9%. Use has been associated with pancreatitis, as well as GLP-1 RAs, which we already talked about earlier, but there's no clear causal effect yet established. And you should try to monitor these patients for clinical signs of pancreatitis and discontinue if this occurs. And this risk is higher if you have someone also on a GLP-1 RA. And so the recommendation is that patients shouldn't be on both a DPP-4 and a GLP-1 at the same time. You should use either or, not both. All right, question 7. Which of the following is correct? A, diabetes can be diagnosed as a random blood sugar of 155 milligrams per deciliter. B, diabetes can be diagnosed by an A1C of greater than or equal to 6.5%. C, diabetes can be diagnosed by a fasting blood sugar of greater than 126 milligrams per deciliter. Or D, both B and C. Right? Both B and C. So diagnosis of diabetes consists of one or more of the following. Patients will need to have an A1C of greater than or equal to 6.5%. Their fasting blood sugar should be greater than or equal to 126 milligrams per deciliter. Or they can have an oral glucose tolerance test of 2 hours with the serum blood sugar of greater than 200. Or a non-fasting random blood sugar of greater than or equal to 200 with symptoms. So one of the ways that the shelf may try to trick you is they'll probably have one of the answers be a 1 hour glucose tolerance test. And unfortunately, you can't use that to diagnose type 2 diabetes. That's typically a test that they use for gestational diabetes. So just keep that in mind. If A1C or fasting blood sugar greater than 126, oral glucose tolerance test 2 hour with a serum blood glucose of greater than 200, or a random blood sugar non-fasting of greater than or equal to 200 with symptoms, polyuria and polydipsia. Question 8. At what age does the United States Preventive Services Task Force recommend routinely screening for type 2 diabetes? Is it A, 15 years, B, 25 years, C, 35 years, D, the United States Preventive Services Task Force does not recommend screening anyone for type 2 diabetes? "35 years of age." So whenever it comes to screening questions, the United States Preventive Services Task Force is your best friend when you're prepping for the shelf. And when you're looking at the shelf, I would commit to memory all of the grade A and B recommendations for the United States Preventive Services Task Force. So the USPSTF, this is taken directly from their website, they're recommending that for patients who are overweight or obese and aged between 35 to 75 years of age, they suggest going ahead and screening patients as part of their overall cardiovascular risk assessment using the screening test that we had discussed. And then clinicians should offer or refer patients with abnormal blood glucose to intensive behavioral counseling interventions to promote a healthful diet and physical activity. This is a category B recommendation. And we're not really sure of the screening interval, but you can potentially do this to 1 to 3 years, depending on who you ask. And just remember high-risk individuals. So anyone over the age of 35 years, anyone that has a first-degree relative with type 2 diabetes, people of color, so African Americans, Hispanics, Asians, Pacific Islanders, or Native Americans are at increased risk. Individuals with a history of gestational diabetes or macrosomic infant, meaning an infant weighing greater than or equal to 9 pounds. People that suffer from polycystic ovarian syndrome, individuals that are overweight, or anyone that has cardiovascular disease, hypertension, hyperlipidemia, or other features of metabolic syndrome. Those individuals, you should consider trying to screen them for diabetes if you can. Mr. Anderson is a 55-year-old male that was seen by you a few weeks ago for a wellness check. His blood pressure at that visit was 125/85. His LDL is 155. Total cholesterol is 200. He got a blood sugar and his result was 150. He states he was fasting. Which of the following is true? A, the addition of metformin will prevent diabetes and is better than lifestyle modification. Or is it B, diet and activity is superior to metformin at lowering his blood progression to type 2 diabetes? All right, it's B. So prediabetes exists. Some people say it shouldn't exist, but it does exist as a category, and it's defined by one or more of the following. A, A1C of 5.7 to 6.4%, or B, a fasting blood sugar of 100 to 125 milligrams per deciliter. So a couple of studies looked at prevention of prediabetes to type 2 diabetes, and the biggest one that came to mind was the United Kingdom Diabetes Prevention Study. And they randomized people into nothing at all that had prediabetes into one group that didn't do anything, or they didn't intervene at all. Another group got metformin, and then another group got lifestyle modification without metformin. And what they found was that while metformin did reduce progression of prediabetes to diabetes, the group that had intensive lifestyle modification had far greater benefit. And this was defined as, trying to lose 5 to 7% of your body weight as well as 150 minutes of activity. And there was clear benefit for the lifestyle modification versus the metformin group. So for individuals with prediabetes, our preferred step is to try and do lifestyle modification, which is what we would recommend anyway. Question 10. Mrs. Henderson is a very pleasant 47-year-old female with a past medical history of type 2 diabetes. She presents for a routine follow-up. Her blood pressure is 124/75. A1C is 6.8%. Total cholesterol is 135 and LDL is 95. Her urine microalbumin to creatinine ratio was 10. Which of the following is true? A, she should start an ACE inhibitor immediately. B, she should be started on statin therapy regardless of her cholesterol levels. C, she does not need a statin based on her normal cholesterol values. D, low-dose aspirin therapy should be started for her. All right, statin therapy. So nearly all patients with diabetes who are older than 40 years meet treatment thresholds with moderate intensity statin therapy. Even if their initial LDL is normal, although you can make an argument that if it's less than 70, they may not necessarily need to be on a statin based on the ACC-AHA guidelines. Other agents that have shown to be beneficial are ezetimibe and PCSK9 inhibitors, which are biologic agents that have probable benefit, although statins tend to be our best first-line medication. So just keep that in mind. Usually PCSK9 inhibitors are reserved for people with high cardiovascular risk that can absolutely not tolerate statin therapy, or they have a significant familial history of familial hypertriglyceridemia or hyperlipidemia disorders. That's genetic. Zetia is typically reserved for an add-on for people that are already on a statin, although you can use it as an alternative. The other medications, such as the fibrates, niacin, haven't really shown to be very beneficial in preventing heart attack or stroke. So, blood pressure targets. Because diabetics tend to have a higher risk of cardiovascular disease, it's really important to help modify their blood pressure because that's also a pretty strong risk factor for future CV events. And making things very difficult for you med students is two guidelines that compete with each other, and they're both accepted. They're both being used in practice. You have the ACC-AHA, which suggests that, for diabetics, you should treat to a target of 130 or 80 or less if they have an increased risk for heart disease and ASCVD, which they do. But then you have the JNC8, which suggests treating them to 140/90 or less, just regardless of their age. So either of those are probably beneficial. I'm seeing, this was older, but I'm seeing a push towards the ACC-AHA, and have another talk about hypertension that can do in the future that, discusses the nuances of these different guidelines at length. Urinary microalbumin measurements are also important because they can help detect early diabetic nephropathy. And the theory is that, you might be able to intervene if they do have albuminuria. So the definition of microalbuminuria is a microalbumin to creatinine ratio of greater than 30, but less than 300. If they're over 300, they have something called diabetic macroalbuminuria. And clinical trials have shown that if you treat someone with albuminuria in the setting of diabetes with an ACE inhibitor or an ARB, you can reduce their risk of progression to end-stage renal disease. So, even if someone has a normal blood pressure, if their UACR or urine albumin to creatinine ratio is greater than 30, you probably could get away with a low-dose ACE inhibitor ARB. But if it's greater than 300, you should definitely put them on that medication. And then you should check it yearly. Aspirin is controversial. Very limited benefit because we know that the risk of bleeding is actually high and sometimes is equivalent to any benefit for primary prevention. The United States Preventive Services Task Force did weigh in. They used to provide pretty comprehensive recommendations regarding aspirin. However, they say that now we should individualize aspirin to our specific patient. And the patients that we should individualize it to would be individuals between the ages of 40 to 59 with an ASCVD risk score of 10% or greater. So an ASCVD risk score is something that you can search online. It's a calculator that takes into effect someone's age, their ethnicity, typically African Americans, Caucasians, and then other, which includes either Asians or Hispanic Americans, etc. Systolic blood pressure, diastolic blood pressure, I believe total cholesterol, and then presence of diabetes, whether or not they're already on a statin, and whether or not they're using blood pressure medications, and tobacco use. And it calculates a risk score. And for anyone that has a risk of 10% or greater, you could individually have a conversation about aspirin, although they're not suggesting this as a global recommendation. So essentially, no real benefit at all in terms of providing aspirin, but you can have an individualized conversation with your patient if they want to. So that's it. The PowerPoint should be available as well with this recording. If you guys have any questions, feel free to reach out to me via email. Thank you.